Genital prolapse. It's a condition that affects a ton of people, but it's often discussed in whispers, if it's even discussed at all. So today, we're going to pull back the curtain. We are going to break down exactly what it is, how it's classified, and most importantly, how modern medicine tailors the treatment not just to the condition, but to the individual person. Let's get right into it. At its very core, prolapse is really a story about a failure of engineering. Our bodies have this incredible, intricate system of muscles and tissues. It's like a biological support hammock that's designed to hold our pelvic organs perfectly in place. So, what we're really talking about here is what happens when that hammock starts to give way. It's all about anatomy, physics, and that delicate balance inside our bodies. Okay, so here's the game plan. First up, we'll get a really solid definition of what prolapse is. Then we'll dig into the different types, based on the anatomy. From there, we'll dive into the critical treatment decisions, look at some really specific patient journeys, and then we'll wrap it all up with the most important takeaways. All right, section 1. Let's get right to the heart of it. What exactly is genital prolapse? Okay, remember that supportive hammock we just talked about? Well, genital prolapse is pretty much what happens when that hammock of muscles and tissues gets weak or damaged. Organs that are supposed to be held up nice and high, we're talking about the bladder, the uterus, or the rectum, they start to drop down from where they're supposed to be. It's a structural problem, for sure, but one with deeply personal consequences. So how does this actually feel for someone? Well, one of the first things that might bring a person to their doctor is having trouble urinating. And this isn't just some random symptom. It's a really specific clue. It often points directly to something called a cystocele, and that's just the medical term for when the bladder has prolapsed into the front or the anterior wall of the vagina. It's a perfect example of how a physical symptom can tell a very specific anatomical story. And that idea, that specific symptoms tell a specific story, that's the perfect lead-in to our next section. Because prolapse isn't just one single thing. It's really a whole category of conditions, and it's all defined by which organ has shifted and where it shifted to. So check out this table. It really breaks it all down for us. Basically, doctors think about the vagina in different compartments. So if you have a prolapse in the anterior or the front compartment, it usually involves the bladder. That's a cystocele. If it's in the posterior or the back, you might see an enterocele or a rectocele. And you'll notice each type has its own specific surgical repair. For example, anterior colporrhaphy is basically a procedure to surgically shore up that weakened front wall. For every problem, there's a tailored structural solution. So we know the what and the where, but what about the how? How do you actually treat it? This is where things get really interesting, because there is no single right answer. It's a deeply, deeply personal decision. And this is maybe the single most important thing to get. Treatment isn't just about fixing the anatomy. It's about fitting the patient's life. A doctor has to think about their age, their overall health, and, critically, their plans for the future. Does she want to have more children? Is it important to preserve menstruation? The answers to those questions can lead down completely different medical paths. All right, let's make this super concrete with an example. Take the enterocele. That's one of the posterior prolapses we saw a second ago. There isn't just one way to fix it. Surgeons have a whole toolkit of options, including different ways to approach it, either through the abdomen or through the vagina. For example, one of the abdominal techniques is called the Moskowitz repair. Now, to break it down in a way that makes sense, just picture closing a drawstring bag. A surgeon places these special stitches in a circle around the weakened area, which is medically known as the cul-de-sac. And then they just pull the strings tight, closing off that space and creating support. It's a really clever and direct mechanical fix. And that idea, the idea of choice, really brings us to the absolute core of what we're talking about today. We're now going to follow several different patient pathways to see exactly how things like age and life plans can lead to vastly different kinds of treatment. This timeline here is a fantastic way to visualize how the whole approach to uterine prolapse evolves over a person's life. The right choice for a young woman who wants to have children is fundamentally different from the best option for a woman over 40 who's finished her family, or for an elderly patient where surgery itself could be a risk. So let's walk through these paths one by one. All right, let's dive into our first scenario. Picture a young patient. For her, the absolute #1 priority is preserving her ability to have children down the road. So any repair has to support the uterus, not remove it. So, for this patient, doctors are typically looking at something called an abdominal sling surgery. Techniques like the Perindar or shared car, they all have the same goal. They create this supportive sling, it's usually made from a synthetic mesh or even the patient's own tissue, that gets attached inside the abdomen to lift and hold the uterus in the right spot. It's kind of like an internal support strap.
Okay, on to case number 2. Here we have a woman, also under 40. Now, she's decided she's not planning any more pregnancies, but she still wants to continue menstruating. So the goal has shifted a bit. Fertility is no longer the main issue, but keeping uterine function is still a priority.
In this very specific situation, the Manchester or Fowler-Gills operation is often the perfect choice. It's a really elegant vaginal surgery. It doesn't use an internal sling, but instead, it tightens the natural ligaments that support the uterus and repairs the pelvic floor. It usually involves removing the cervix, but keeping the main body of the uterus, which allows menstruation to continue. It's a perfect compromise. Now, for our third pathway, and this is a really common one. This is a woman over 40 who is multiparous. That's a medical term that just means she's had several children. At this stage in life, preserving the uterus is often no longer a priority. The main goal now is a permanent, definitive fix for the prolapse.
For a patient like this, the standard of care is often a vaginal hysterectomy combined with a full pelvic floor repair. This procedure, sometimes called ward Mayos, gets right to the root of the problem by removing the uterus through the vagina and then rebuilding all those underlying support structures. It provides a really comprehensive and lasting solution.
But what if surgery isn't the right path for someone? This is a critical crossroads. On one hand, you have the definitive, permanent fix of a surgery like a hysterectomy. But on the other hand, you've got a non-surgical option called a ring pessary. It's a simple device that can manage the problem without ever needing an operation. So you might be wondering, who is this pessary really for? Well, it's perfect for a few key groups of people. It can be a temporary fix during pregnancy or in the postpartum period, what doctors call the puerperium. It's also a great choice for younger women who just want to avoid or delay surgery, or for any patient where a major surgery is just too risky because of other health issues.
And that brings us to our final scenario: an older patient who is medically unfit for a major operation like a hysterectomy. But that doesn't mean there are no options. There are less invasive surgeries, like the Lefort's repair, which works by stitching the front and back walls of the vagina together. This creates a really strong supportive barrier, and it effectively fixes the prolapse without all the complexity of a bigger procedure.